Here's a scenario that plays out in psychiatric offices across the country every single day. A patient says, "I can't focus. My mind is always racing. I can't sit still. I procrastinate on everything because I get so overwhelmed I freeze. I forget things constantly because I'm juggling too many worries at once." Now here's the question. Is that ADHD? Is that an anxiety disorder? Or is it both? The honest answer is, from that description alone, a clinician cannot tell you. And that's not a failure of the description. It's a genuinely accurate reflection of how much these two conditions overlap on the surface. Today, we're going underneath the surface. Let's start with why this overlap exists in the first place, because understanding the mechanism makes the distinction much easier to grasp. ADHD, as we covered in episode 1, is fundamentally a disorder of attention regulation and executive function, rooted in differences in dopamine and norepinephrine signaling and prefrontal basal ganglia circuitry, present from childhood. Generalized anxiety disorder, and anxiety disorders more broadly, are fundamentally about excessive, difficult-to-control worry and a heightened threat detection response, often accompanied by physical symptoms like muscle tension, restlessness, and sleep disruption. Here's the key insight. Both conditions can produce concentration difficulty, restlessness, and forgetfulness. But they get there through completely different mechanisms. In ADHD, concentration difficulty comes from inconsistent attention regulation. The brain has trouble sustaining focus on tasks that aren't inherently stimulating, regardless of whether the person is worried about anything at all. In anxiety, concentration difficulty comes from a mind that is preoccupied. Cognitive bandwidth is being consumed by worry, rumination, and threat scanning, which crowds out the ability to focus on the task at hand. Same symptom on the surface, different engine underneath. This matters enormously for treatment, which we'll get to. But let's first go through the specific differentiating features clinicians actually rely on. Differentiator 1. The nature of the racing thoughts. In ADHD, the subjective experience is often described as thoughts jumping rapidly between unrelated topics, tangential, associative, sometimes exciting or creative, not necessarily distressing in content. In anxiety, racing thoughts tend to circle around specific worries, often repetitively, frequently catastrophic, or worst case in content. What if I get fired? What if something is wrong with my health? What if they're upset with me? A DHD-related mental activity tends to be broad and scattered. Anxiety-related mental activity tends to be narrow and looping. Differentiator 2. Onset and timing. ADHD symptoms, by diagnostic definition, trace back to childhood before age 12, and tend to be relatively consistent over the lifespan, even if severity fluctuates with life demands. Anxiety disorders can also begin in childhood, but adult-onset anxiety is extremely common and is often clearly tied to specific life stressors, transitions, or accumulating pressure. A new job, a health scare, a relationship ending, chronic overwork. If someone's concentration difficulties began clearly and specifically in adulthood, coinciding with a stressful period, and there's no meaningful childhood history of inattentive or hyperactive symptoms, that points toward anxiety rather than ADHD, even though the day-to-day experience might feel remarkably similar. Differentiator 3. What happens when the external pressure is removed? This is one of the most clinically useful questions we ask. If you put someone with pure anxiety in a low-stress, low-demand environment, a relaxing vacation, a quiet weekend with nothing pressing, their concentration and restlessness typically improve substantially because the underlying driver, excessive worry, has less to worry about. If you put someone with ADHD in that same low-stress, low-demand environment, their attention difficulties often persist, or can even worsen, because ADHD isn't fueled by worry. Sometimes a lack of external structure and urgency actually makes task initiation harder, not easier. This single question, does it get better on vacation or does it actually get worse, is genuinely one of the most useful differentiators in a clinical interview. Differentiator 4. The emotional tone of the restlessness. In ADHD, physical restlessness often has a neutral to positive or simply energetic quality. Fidgeting, needing to move, feeling understimulated by stillness. In anxiety, restlessness tends to carry a dysphoric, uncomfortable, apprehensive quality. A keyed-up, on-edge feeling connected to a sense of impending threat or dread, sometimes with physical symptoms like a racing heart, sweating, or a knot in the stomach. Differentiator 5. Response to novelty and interest. Someone with ADHD, even amid real struggle, often describes moments of intense, absorbed focus, hyperfocus, on something genuinely engaging, where time disappears entirely. This capacity for deep engagement is a hallmark of ADHD's inconsistent rather than globally deficient attention system. Someone with a primary anxiety disorder more often describes difficulty focusing across the board, including on things they'd normally enjoy, because the anxiety intrudes regardless of the activity's inherent interest level. Now here's the part that makes this genuinely complicated, and it's the reason this entire episode exists rather than being a 5-minute aside. ADHD and anxiety disorders very frequently co-occur in the same person. Research consistently shows elevated rates of comorbid anxiety disorders among adults with ADHD compared to the general population. There are a few reasons for this. First, some anxiety is a direct downstream consequence of living with unmanaged ADHD. Years of missed deadlines, forgotten commitments, and being told you're not trying hard enough will understandably produce real, clinically significant anxiety about performance and reliability. Second, the two conditions may share some underlying vulnerability in certain individuals. Third, the chronic unpredictability of ADHD symptoms, never quite knowing if today is a focused day or a scattered day, can itself become a source of anticipatory anxiety. Let's walk through 2 examples that illustrate this properly. First example, anxiety masquerading as ADHD. Rachel, 33, came in describing what she called ADHD symptoms. Can't focus at work, mind constantly racing, forgets things, feels restless. On careful history taking, it became clear that her racing thoughts were almost entirely about a specific, ongoing situation: a strained relationship with her mother and mounting financial stress after a divorce. There was no childhood history of inattentive or hyperactive symptoms. Her report cards were unremarkable. She'd never struggled academically, and she described her mind as usually pretty organized before the last 18 months. Her symptoms had a clear onset tied to identifiable stressors, and notably, she described that on a recent stress-free vacation, her concentration returned to completely normal within about 2 days. This clinical picture points strongly toward generalized anxiety disorder, not ADHD, and her treatment, which included therapy and addressing the underlying stressors, led to substantial improvement, confirming the impression. Second example, genuine comorbidity. Tom, 27, had a clear childhood history of inattentive symptoms. Teachers' comments about daydreaming going back to second grade, chronic difficulty finishing assignments despite obvious intelligence, a lifelong pattern of losing things. As an adult, on top of this baseline, he had developed significant anxiety specifically about work performance, worrying obsessively that he'd miss something important, checking his email compulsively and experiencing genuine dread before meetings, terrified he'd forget something and be exposed as incompetent. Here, both conditions are present, and importantly, they're interacting. The ADHD created a real pattern of missed details and forgotten tasks over years, and that real pattern generated legitimate, learned anxiety about repeating those mistakes. Treating only the anxiety here would leave the underlying executive function difficulties unaddressed, and treating only the ADHD without addressing the anxiety that's built up around years of real setbacks would likely leave him still feeling on edge even if his organization improved. This is a case for integrated treatment. Clinical perspective on this. This is exactly why a proper psychiatric evaluation, which we detail fully in the next episode, always involves a structured developmental history, not just a symptom checklist. A clinician has to ask not just, do you have trouble concentrating, but since when? Does it fluctuate with stress, or is it fairly constant? What happens on vacation? What were you like as a child? And what's the actual content of your racing thoughts? These questions are how you tell an engine problem from a fuel problem, so to speak, even when the car is stalling in exactly the same way. Let's clear up common misconceptions. Misconception 1. If I'm anxious, I can't have ADHD because anxiety explains everything. This is false, and it's a particularly costly misconception because it can lead to years of anxiety treatment, therapy, sometimes medication, that helps the anxiety but leaves a real underlying attention and executive function problem completely unaddressed, with the person wondering why they still can't seem to get organized even though they did the work on their anxiety. Misconception 2. Stimulant medication for ADHD will make anxiety worse, so if someone has anxiety, ADHD treatment is off the table. This oversimplifies a genuinely nuanced clinical picture. It's true that stimulants can, in some individuals, exacerbate anxiety symptoms, and this requires careful clinical judgment, which is exactly why medication decisions belong to a psychiatrist managing the full picture, not a blanket rule. But for many people with genuine comorbid ADHD and anxiety, appropriately treating the ADHD actually reduces anxiety over time, because so much of the anxiety was a downstream consequence of ADHD-related struggles in the first place. We'll cover this in much more detail in Episode 6. Misconception 3. You can just tell which one it is by how the person acts in the room. Clinical presentation in a single appointment is not a reliable differentiator. Anxious people and people with ADHD can both appear fidgety, distracted, or scattered during a 45-minute visit. This is exactly why a single visit isn't sufficient for diagnosis, and why history matters so much more than in-the-room observation. Practical takeaways. If you're trying to understand your own experience, ask yourself when this started. Ask whether it's better or worse under low pressure, low stimulation conditions. Ask whether your racing thoughts are broad and associative or narrow and worry-focused. Ask whether this was present in some form in your childhood or whether it emerged clearly alongside a specific life stressor. None of this replaces professional evaluation. We want to be very clear about that. But it will make you a much more useful historian when you do sit down with the clinician, and it will help you understand why the evaluation process, which we're covering next, needs to be as thorough as it is